Good evening, everyone, if you're watching this in real time, or good afternoon or good morning if you're watching a recorded version. Thank you for joining us for the third of these Nutritia Podinars, where we've looked at, the complex interaction between the gut microbiota and also a variety of gastrointestinal illnesses and food allergies. If you've seen the previous two, you'll know that's a relatively informal discussion based around a clinical case, but really using the expertise of our panel. This evening, I'll be chairing with Dr. Shannon Brothers, who is a paediatric allergist at Starship, and we also have two other members of the wider group. We have Kathy Beck, who many of you will be familiar with because of her role with Askia, and also as a paediatric dietitian working in Queensland, currently in private practice, but previously in both private practice and at Queensland Children's Hospital. We've also got the medical affairs director for Nutritia, who I met in days gone by when we could travel in Sydney, but she's now back in the Netherlands. So we certainly got lots of expertise to call on. We have obviously questions that we're very happy to be asked. It really helps. If you put them into the chat, not the chat box, the information link that you have, then Shannon will hopefully filter them to me while I'm talking and vice versa. But certainly the more interactive, the better. I'll start with the case. A few disclosures, none of which pertain to the case that we're going to discuss. So this may seem familiar to many of you. We often see these children, don't we, these babies at various different ages, and we take a history, in a sense, looking for things that may have increased their risk of allergy and indeed may have affected their gut flora. So this was a girl I saw at about 7 or 8 months of age. She'd had a term cesarean because of a previous cesarean. She was growing well. Her mum was breastfeeding her, and she started solids about a month and a half ago, and really had been very well, and had an older sister who had some mild eczema, but was pretty well. So I suppose thinking about this at the sort of microbiome level, I'll ask the two non-clinicians, when you sort of hear this story of a family history and the cesarean, and the sort of atopic history in the sister, Patricia, what does that mean? What are the implications for this little girl's gut flora compared to another baby? Does it matter? Is it relevant? As we're thinking about what might be happening down the track with food allergies.
I think the microbiome, the microbes in the intestine of the infant are very important, especially for immune responses. And we know that the microbes that the baby is exposed to at birth and the following months are the microbes that are triggering the development of a mature immune system. So if an immune system is not functioning correctly, it's suggestive that the wrong microbes have been present in that baby. And when you look at the fact that it was a C-section baby, it's exposed mostly to mum's skin microbes in the hospital environment, as opposed to the normal vaginal microbes. So yes, the microbiome of the baby will be contributing significantly to it. And it changes with time. And it's interesting that with time, as the microbiome develops, the baby's immune system develops too. And issues associated with food intolerance disappear.
Yeah, very much so. It's that sort of immune maturity. And I think obviously we have an allergist immunologist, so she can speak to that in greater depth. But I think we recognise that, don't we? That there's a whole host of things that are going on that encourage children to grow out of often these non-IgE mediated allergies. Probably the same question to Rocio. What do you think about this setup? What sort of literature or evidence is there that could speak to what this baby is at risk of, or what we might be doing?
Yeah. No, thank you. And I fully agree with what Patricia said. There are really, if you can find a very consistent finding on the differences on the microbiota between something. It is when you compare infants born by C-section and vaginal delivery. It's the most consistent finding in all the studies across the world. They find exactly what Patricia was describing. What is very interesting is that the dysbiosis of this microbiota occurs at the moment of development, as Patricia very well said, and you can read in the literature that it catch up in time, that actually these differences get smaller and smaller, but it occurs as just an important moment of development that has long-term consequences. So I was indeed reading a recently published study with 7 million infants that were born from different countries, England, Denmark, including Australia, and Scotland, if I'm not mistaken, where they do see huge impact on increased risk of infections, even at 5 years of age. So what it happens in this period is so important, and we do have the proof that this disturbance of the microbiota, as Patricia said, has consequences on the development of the immune system with infections, but also asthma. We do see a link between C-section born infants and risk of asthma later in life. So definitely something to keep in mind.
And let's just say, Shannon, that you were the clinician looking after the 2-year-old with the eczema, and this mum had said when she'd taken the 2-year-old to see you, when she was pregnant with this new baby, look, Shannon, look, my child's eczema, look, it's okay now, but it was pretty horrible in the first year of life. Is there anything I can do now, Dr. Shannon, while I'm pregnant with this new baby, to reduce the likelihood of my next child having eczema or another, allergic illness? I use a lay term. What advice would you give to that mum who obviously had to have the cesarean because if she's going to have one? Any other dietary medication strategies that you would encourage for this mum who's got the previous atopic child?
So I think this is where I struggle with this on an individual level, because we know about this on an epidemiological level in terms of risk factors. And we know at an individual level what the risk factors may be, but what I struggle with is how we modify those and how we modify them before they're too late. And so we know that there's some data for eczema and, for example, probiotics given during pregnancy and to newborn babies for the first several months of life, and that may or may not, but that there is some data that shows that might alter eczema. But until now, we've not had very good data to show whether or not that had an effect on food allergy. But there is quite a lot of data now that shows that it doesn't have an effect on food allergy. And so I would not recommend, for example, probiotics to be given to the pregnant mother or to the infant. I'm not saying that wouldn't that's not a harmful thing to do necessarily, but there's no evidence to show that would prevent development of food allergy specifically. And
what about dietary introductions for this baby, Shannon? This is, obviously there's not a specific allergy, but this is an atopic family. Would that have any influence on what you would suggest about allergens in terms of introductions for the new baby when they were born?
Absolutely. So there's good evidence to show that introducing food allergens early will establish food tolerance during a window of opportunity where we know that the gut immune cells are tolerogenic when introduced to those foods early, particularly while breastfeeding. So early introduction of any allergenic foods somewhere around 6 months of age, ideally whilst breastfeeding. So including foods like cooked egg and peanut is definitely protective for IgE-mediated allergy, at least. We don't know that for non-IgE-mediated allergy or intolerances.
And Kathy, this is not directly related to this case, but I'm sure you see patients who are convinced that a variety of gastrointestinal symptoms in their newborn baby are related to, to foods that they're eating while they're breastfeeding. And we discussed this in the second the Podinars, but you often meet these mums and they're on, 4 food, 6 food exclusions, and sometimes even on a few foods diet, which is obviously catastrophic for the mum and probably not beneficial for the baby. So my question is almost the other way around. How do you, as a clinician dealing with these mums, try and unwind that and normalise their diet and explain that it's probably not that helpful, and the sort of the detrimental effects to the mum of doing that to herself? How would you go about doing that in clinical practice?
Well, firstly, it actually is very common when parents, or mothers, I should say, restrict their diet. And so usually, the first questions I will ask is, have you seen any improvement in your baby since you've done this, to establish whether, is it a real sort of reason to use? 9 times out of 10, they haven't seen any improvements. And I'll ask them about how that, well, obviously I'll check how the baby's growing. I'll ask them about how their nutrition is, what their weight is doing, what their weight is in relation to their pre-pregnancy weight. 9 times out of 10, they're actually happy they realise when I ask those questions that what they have done has not actually created any benefit for their child. And so they're usually open to introducing foods. Then I get on to, we know that overly restricting diets in infants is not good for long-term, development. But also we know that introducing the allergenic foods before 12 months, starting at around 4 to 6 months, prevents allergy. And so often they don't know that. So once I talk to them about the fact that we have this window of opportunity between 5 and 7 months when infants are actually receptive to actually being fed solid foods. And so provided they're developmentally ready to eat foods, we say to introduce a wide range of family foods based on what the family eats, and also introducing, once they've got a few foods in, then introducing those common allergenic foods. And usually I show them some evidence and some consumer websites with some resources, and often I can turn them around.
That's a great answer, very, very clinically relevant. I don't know if you heard, but probably the majority of our audience are dietitians, Kathy, so I think that sort of advice is really useful.
Yeah.
And so this is back to Patricia, really, in the same sort of context. So which of the probiotics has been shown to have a positive impact on sort of eczema reduction to mums and to the babies? And is there any sort of new information on what probiotics, Patricia? I agree with Shannon. It's, we don't really know what we're doing, but sometimes we're left with the option of wanting to do something. Is there an evidence base which suggests which probiotic I should recommend to a mum and a baby in terms of allergy prevention?
Yeah, thanks for that really important question, because using the term probiotics generally is very misleading, because it's like saying humans can do this. Well, don't give a baby to me to take care of. I might dissect them and take out their intestines or something. So I think it's really important that we distinguish that not all probiotics are the same. And not all, generally it's lactobacillus or bifidobacteria, but it's also, that's the genus name. So, for example, the genus and species name is Lactobacillus acidophilus, like we are Homo sapiens. But once again, humans are all very different. So we need to have the strain designation or the name of the particular probiotic to know that that particular probiotic is effective. And there have been studies showing that probiotics administered to mum or to bubs do help with atopic dermatitis. But some of the positive studies are small and haven't been repeated in larger studies. There's been the meta-analyses and the reviews of the data across studies. And the difficulty with doing that is there are different protocols, different study designs, different strains, different dosages, different subjects. And so the jury is definitely out on the use of probiotics for infant atopic dermatitis and asthma, and also if administered to the bub. So I totally agree with Shannon's comment that as a doctor for these kids, you don't know which one to use. But there are studies showing that it's efficacious, but you need to know the particular strain. that's being used. And I recognize that as a doctor, you can't possibly have the time to dig deep down into the particular strains that are efficacious. But there are strains, and I've been involved in studies where we have improved atopic dermatitis in infants. Perhaps Rosia can comment further on the strains.
Yeah, no, thank you, Patricia. And I always say the best advice on probiotics, I heard it from you in Sydney. Indeed, really looking at the strain level is very important. They are all very different, and we don't really know the mechanism of action. And also, is one probiotic strain alone able to do to correct whatever has to be? So we don't know the mechanism of actions. We know the microbiota is linked to the development of the immune system, and also differences of microbiota have been seen in allergic infants. But then how can we correct that with one probiotic, and how the probiotic can interact with the immune system is not always known. So from my opinion, we always look especially on steering the microbiota in the right direction with species that are normally found in breastfed infants, because this is very important to really create the natural environment. So for me, species like Bifidobacterium breve, infantis, those are the ones that you really find in infants. So that's already going to the species level. And then there are strains, and we do work, and we did a lot of research with the Bifidobacterium breve M16B, which was isolated from a breastfed infant. And we do have data that you can impact the microbiota, have an effect. I agree with Patricia, the studies are not always big enough and powered to really have such a strong conclusion to say it works in a population, or we don't have the meta-analysis, because meta-analysis is a bit difficult when you don't have a lot of studies with the same probiotic. But definitely the Bifidobacterium breve M16B, it's an infant type species that has been shown to modulate the microbiota in the right direction. And we have even data in infant born by C-section where we can close that gap, as we mentioned before, and have an impact, for example, on skin-related problems. It's not food allergies, but on skin-related problems, we do see a difference. Yet the studies were still small. So research needs to be done to have more conclusive results.
And perhaps I can add one further comment on to the MV16 story, is that I have been part of studies in Perth where we have administered it to preterm low-weight babies, the very sensitive babies. And the probiotic is live, and we have had improvement in health with no adverse events in the studies. So it's always the question of, is it safe for the very young? So those studies are giving us a lot of confidence with the MV16.
I mean, obviously, it's not necessarily within the spectrum of this talk, but I guess there's, the Cochrane reviews on prematurity and neck, and also prematurity and, on death in neonatal units has led some neonatal units to use probiotics quite widely. You can see the concern around these babies, and you can see that there is a lot of concern from the neonatologist about using them. So what's your reading, Patricia, of the literature as pertains to necrotizing enterocolitis prevention or death on the neonatal unit with regards to probiotics? Do you have a sense of what those studies are about? I mean, because I must admit, I probably looked at the last Cochrane review, and it's slightly favourable. It's not going to make me jump up and down.
Yeah, I mean, basically, one of the challenges of showing improvements against necrotizing enterocolitis is the powering of the study, because the incidence of necrotizing enterocolitis is quite low. So therefore, you need very large studies to show benefits. And the team that I work with together in Perth at the ICU unit for the preterm low-weight babies, they have a particularly high success rate of improvement of babies. So it's hard to identify the one or two necrotizing enterocolitis babies and the fatalities when it's very small numbers. But when I started to work with that group, we were particularly careful which probiotic was administered, because safety aspects are so important. And it's not just a probiotic for these sensitive babies, but it really has to be a very well-characterized, well-studied, extensively administered to infants to have any confidence that the safety aspects are addressed. So just saying probiotics for the small babies, I would definitely be very cautious.
No, agreed. That's really good advice, Patricia. Back to the case. So basically, we've now got this baby who's had solids introduced, but actually, as I often say to the junior doctors, babies present unwell, and your first three diagnoses are sepsis, sepsis, and sepsis. And I'm sure that was true when Shannon and I were residents in the emergency. A sick baby was septic until proved otherwise. So you can see why this baby who had vomiting and diarrhea, who was genuinely shocked and needed normal saline, they thought this baby must be septic, and then did all the things that we do with sick babies: antibiotics, lumbar punctures, fluids. But I guess what was different about this baby, and I suppose relevant to the case, was that really this baby, after a couple of boluses of fluids, suddenly perked up. I think septic babies who are that unwell, they're not like that. They're a bit better after fluids, but they're not sort of night and day different. Whereas this baby actually was bang, oh, I'm okay now. Also, I guess, no one else had been unwell at home, so it seems unlikely that a baby's not going to childcare, that's gastroenteritis. So I suppose, to be fair, they just thought, oh, it's culture negative sepsis, we'll just all move on. And I think that's fine. It's probably a good outcome. The baby got better. At 2 days, blood cultures, lumbar puncture were all negative, and the baby went home. But I suppose, and this is the, I guess the $1 million question, isn't it? Would we have known? But I don't think we would have known, to be honest, because these babies look like they're septic. But anyway, this baby then represented to the emergency department with exactly the same story, really very similar examination findings, had been completely well in between times, and no sort of, funny foreign travel, otherwise sick kids. And she'd had rice and chicken for lunch, and this was only the second time that she'd ever had rice, having had chicken and vegetables before. Shannon, what's going through your mind now?
So for me as an allergy specialist, there's only one thing going through my mind, so that's probably not fair. Would you like me to go broader than that before that one?
No, I'm happy, because I guess if you're thinking of a single diagnosis, which is fair, what is it about the story I've given you that makes it so clearly that diagnosis is probably the question I'd pose. Because I guess you're right. It's obviously A, it's easy on slides. It's B, easy if you're an allergist. But actually, at 3 a.m, when it's the pediatric resident who's half asleep, what do they need to look out for?
So there are a few things. One is it's repeatable. Number two, exactly the same. Number three, delayed in onset, at least on this occasion, because we didn't have a time frame from eating a meal on the previous occasion, but I'm sure you can tell me that. So was that also about 2 to 4 hours after a meal?
Yeah, within a few hours. So it was the dinner, the previous meal, but it was, ED mid-evening. So exactly the same time scale, a few hours. And
was the presentation in terms of vomiting, predominantly diarrhea, shock, it's reproducible as well? And what food was implicated? Well, we didn't think food was implicated the previous time, understandably.
No, the first time round we didn't. It was only the second time round when questions were posed around what the food had been on the previous occasion. And whilst the baby had chicken lots of times, it was only the second time that, they said the second time the baby had rice.
So that and the type of food. A few other things I'd want to know. It's quite possible on this occasion, no further investigations have been done, but I'm sure on the first occasion we know they were done. And so I'd be quite interested to know what a full blood count was at that point, particularly if there was leukocytosis and thrombocytosis.
There were, and I guess first time round, of course, they thought it was probably the sepsis that did that, as it probably, statistically, it's probably more leukocytosis that relates to sepsis than allergy. But yes, on both occasions, there were exactly the same findings, really, on the FBE.
And then I think lastly, what I'd like to know is temperature on both occasions.
So I can't remember on the first occasion, but actually the second time the baby came in, the baby was sort of shocked. So actually it was cold, not hot, if that makes sense.
And so for me, putting all of that together then, particularly if there was some hypothermia as well, and this is reproducible, my most likely diagnosis would be food protein-induced enterocolitis syndrome.
Which is obviously, what the baby was thought to have clinically. And look, I don't know about you, Shannon, I'm a bit older than you, but certainly when I was a medical student, I'd never heard of FPIES. And now I would teach it to the medical students, not in depth, but certainly in awareness of what it is. So I think like a few diagnoses that we probably look after as allergists and gastroenterologists, I think eosinophilic esophagitis is another one of those. This is a diagnosis that really didn't used to be a thing and suddenly is a thing. What do you make of that? How can that be? Did we used to miss it, or is it genuinely a new thing?
I don't think we used to miss it. I think it's yes, with anything there's ascertainment bias, but I think in a similar way to eosinophilic esophagitis, yes, there was probably a little bit of it around, but not a lot. I mean, I think to eosinophilic esophagitis now, and I kind of go, I remember when I was involved in a patient, a single patient, maybe once a month or once every 3 months. Now we've run EO clinics every 2 weeks that are full, of EO patients that we run combined with our gastro colleagues. FPIES not as common, but no. I don't think that I think it is new. But also there's so much more so many more people are looking out for it now. So the situation I often find myself in now in terms of diagnostic challenge is I'm often referred this child on that first presentation, and diagnostic features are that it's a reproducible reaction, and that's part of the diagnostic criteria, and yet I'm having to decide on the basis of that first presentation. And usually my ED colleagues are spot on, but it does present a dilemma now.
Yeah, I mean, probably the same with EOE, because they know that it's the commonest cause of food getting stuck, of food bowel obstruction, that, when the child comes into ED with a bit of sausage stuck, the thought is no longer it's a teenager who took too big a bite, it must be EOE. And look, I think that's good. It's good that there's recognition of these possibilities, isn't it? But I might come back to you, but I'd probably go to Kathy now. So let's presume now that the diagnosis of FPIES, as it often is clinically made. We'll get Shannon to talk through what she does in terms of investigations later. But what would your management advice be to a family who've got a newly confirmed FPIES to rice? No other food reactions to date. Kathy, what would you sort of walk through with the family?
Yeah, so firstly, I would normally see these patients days to weeks, sometimes a month after diagnosis. And so a lot of these families would have such a fright, especially having had it twice with a little infant, and, being so sick and going in an ambulance and having IV fluids, and they become extremely fearful of feeding the baby. So in many occasions, they actually stop all solid foods. So I think this baby, say, is 7 months. Most of them are around 5, 6, 7 months.
Yeah.
And so then you've got a situation often where you need to then convince these very anxious parents to actually start to reintroduce foods. And so that's one thing, talking to them about getting a range of family foods in for the baby, actually showing them how to eat. So all of the basic things that a dietitian does with expanding variety and types of foods. One thing that we would consider, and usually the allergist, immunologist would advise on this, if it's a rice FPIES, often they're advised to avoid oats as well. Then other than that, every other food is advised to be introduced. Majority of infants will have FPIES only to one food. And so then we would really encourage lots of introduction of food. So one new food every day. Incorporating the other advice, which is actually introducing the allergenic foods or the common allergenic foods before 12 months of age. So these families tend to be also, as I mentioned, very anxious. So what I do personally is I provide a lot of support, and many of my colleagues do as well. So they have our email address and they're encouraged to email us if they have questions. I often ring them, have a phone or a Zoom appointment every 2 weeks, because if you actually leave them to their own devices, often they'll say, look, I'm happy to just only give them 5 foods until they're 12 months old. And we know that that's not good. And so usually trying to educate them about why we need to get foods into the diet to expand the diet, because of course that's another factor that influences the gut microbiome, is actually having a big range of foods in the diet, including obviously fruits and vegetables and grains.
I think you're right, Kathy. You see a lot of these kids with, say, not just FPIES, but even the kids who've got sort of allergic proctocolitis, where there's been some exclusions, that you've really got to break through that anxiety around the introduction of foods. Because you're right, often, I see them a bit late in the piece, and you've got these kids who are 9 or 10 months, and the mum's saying, he's only got 4 or 5 safe foods, I've got to go with, one food every 2 weeks, I'm terrified. And I guess how, that's... So any practical tips for how you sort of break that cycle of worry?
Well, my practical tips are using the resources we have available with the Prevent Allergies and the National Allergy Strategy Prevent Allergies, infant feeding advice, the ASCIA advice around FPIES about introducing lots of foods, and just general feeding advice. Also having sort of a bit of a feeling for how the parents are feeling. Often you'll have mothers in particular who have extreme anxiety, and it's actually sort of opening that discussion about how they are feeling, how they are coping. And so I've had several parents that have had to have psychological and sometimes even psychiatric input, because that absolute horrific experience that they've had, they do need a bit of help to get over that, if you know what I mean, to feel confident enough to feed children, to feed their infants at home.
Definitely. And I think...
Sorry,
you go.
Yeah, sorry. I was just going to say also, a lot of these children, because there's so much parental anxiety, and sometimes they've also had an adversive experience with food, will often need feeding therapy. And so being aware of, we need to watch this child and making sure, are they progressing through introducing a range of foods with the family? And if they're not, it's really seeking that feeding advice quite early.
Thanks, Kathy. That's really very helpful. Look, I think in terms of that anxiety, I think you're right. I think, there are numerous studies looking at quality of life experiences for parents of families with allergy, and particularly anaphylaxis. And there are some studies suggesting it's more stressful for a family to have a child with anaphylaxis than a child undergoing chemotherapy for leukemia. And, you can sort of see why that might be the case, given, there is at least light at the end of the tunnel in one of those scenarios potentially. So I think you're right. It is sometimes supporting those families through the anxiety around what happens when the kid goes to school, to kinder. There's a whole list of things, isn't there, really, that's very stressful for them.
One thing I do say to families, and they come to you at probably the worst moments of their lives with this little baby, and I say, look, just so you know, things will get better, and you can expect your child to be able to go to school without having FPIES and even kidney. So it's not going to be this bad forever. And so trying, I suppose, at that early stage to help them feel a little bit better about the fact that their child is going to be okay in the long term.
Agreed. Shannon, sort of back to you. So the child arrives at you in allergy clinic, maybe after the second episode. Is there a role in you doing any allergy testing at all? Do you do it because, there might be other reactions, depending on which food it is involved or implicated? Do you exclude other foods as well as the culprit food? What sort of advice are you giving, Shannon, to to a variety of different foods about other food reactions, when you're going to introduce? What's your sort of first consultation with new parents with FPIES discussion?
So no role in terms of testing. As we know, there's no diagnostic testing. Testing for IgE-mediated allergy, not helpful. So doing skin prick testing or serum-specific IgE testing, it has no role here. And I explained that it's a non-IgE-mediated gut allergy, and that we don't have any tests available, but hopefully if they've come to me after a second reaction, we've had a reproducible reaction, and that pretty much clinches the diagnosis. Otherwise, I have to go off a very detailed history. In terms of foods, I completely agree with Kathy. Rice is the most likely culprit here, and I would suggest exclusion of oats as well. And also completely agree with Kathy. We know that for FPIES, it's typically one food. And studies differ. In the US, the studies have shown 2 or 3 foods might be implicated, but definitely in Australia, and we couldn't expect New Zealand to be much different. Sam Nair and Diane Campbell have very nicely shown that in a large cohort of infants in Australia, it's one food group. And so I try and reassure them that we know what the culprit food is. It's likely to be that one food. They can safely introduce the other foods. And I completely agree with Kathy. The more hand holding, the more you can reassure them on a regular basis, the less likely you are for them to go down that rabbit hole of excluding additional foods, and coming back to you with a list of 4 safe foods that they're only want their child to have. And I have had that scenario, I agree, Kathy, where they come to me and kind of go, I don't want my child to eat anything other than these 4 or 5 foods. And I've had that with EO as well, because non-IgE mediated allergies can be frustrating because I can't do a skin prick test or show them a blood test result. What I have is history. I also reassure them, like Kathy does, their child will outgrow this, and at some point we'll be able to do a challenge down the line.
Can I ask you about challenges? Yeah. It's a 2-part question, actually, Shannon. When do you say to parents we're likely to do a challenge? And do you make that challenge, in hospital, out of hospital, cooked, non-cooked, all those sorts of things that the parent will want to know from you?
So it very much depends on the food. Also depends on which study you look at. But for liquid foods, so for example, cow's milk, even soy, when there are studies now that show that those are outgrown much quicker, between a year a year or 2 of age. Particularly an Israeli study that showed that it's outgrown a lot quicker. For our grains, and we can include rice and oats in that, it's probably somewhere around 36 months of age. Probably between 3 or 4 years of age, I'd be looking at it. And for our other solid foods, like if this had been chicken, I'd be far less. I mean, I'm still optimistic this child is going to outgrow it if it was chicken, but it's probably going to take longer. So probably more like, 42 months and beyond. How I would do it, particularly with this history, I think it does depend on history. We always do them as as a day-stay case, but particularly with this sort of history, I would want this done in a supervised way, using an FPIES challenge protocol and in the day-stay unit, and then observing for 4 hours afterwards, because it's a delayed reaction. So it's a good day for the parents, a whole day, half day to whole day of waiting. And I did probably in this child recommend somewhere around 4 years of age.
Great.
In the meantime, I want this child to have the ASCA FPICE action plan.
Yeah, they're very useful, aren't they? And not only are they useful, they're really reassuring for parents, I think, the action plans, aren't they? I think it's a win-win, isn't it? It's useful if the child has an event. It's a bit of a blanket to wrap around the parents. They take it off to school, kinder, isn't it? Or to childcare, whatever they're doing. This is a question really for we'll go Patricia and then Rossio. But so I remember when I was a junior doctor, one of my bosses said, all we need to do to stop allergy is to scoop up a bit of the mum's poo and give it to babies when they're born. Patricia, would that be a logical approach to take?
Perhaps 200 years ago, when we didn't have the medical advice we have and the preparations, etc., and there was no other alternative.
He was a very old consultant, Patricia, so he might have been alive in the last century.
But you know, there are risks. There are risks associated with that. So I think I would definitely be going down many other routes before I would even consider something like that. I mean, there are studies.
I suppose I am partly joking, but there is a bit of a literature around vaginal seeding, isn't it? And that's what I'm sort of getting at. And I would not claim to be an expert in them. I've read a couple of them. But
vaginal seeding is a little bit different from the poop, because the stools are a very complex, diverse microbiome, whereas the vaginal, during vaginal delivery, the baby is exposed to vaginal microbes. And we know that vaginally delivered babies are more healthy than C-section babies and have lower incidence of allergies and things like that. So the vaginal microbes can be useful.
Do you think we've underdone pursuit of that? I mean, because it seems logical, doesn't it? If you articulate the view that those vaginal microbiomes are useful, they're not going to get them if they come out of the stomach. They're going to get, skin flora. Yeah. Do you think we've sort of shied away from doing that, or is it just a bit too difficult to do safely? Do you have a gut feeling? Because I always think it's very logical, the idea of it. Yeah,
I mean, it's logical, and I guess the safety issue is my biggest concern. So, my comment is also linked to Roche's comment earlier that can a single microbe have the benefits, and using the microbes that are, for example, in breast milk and things like that. So if you're making a simulated vaginal secretion, which had the most dominant microbes that are in vaginal flora, then I think that could be safe, and whether it's 2 or 3 or 10 or whatever it is. So the concept is correct. I'll stay away from the poop and the fecal transplanting, but the vaginal, I mean, as the vaginally delivered baby is being exposed to them.
Thank you. Rossio, do you have a view on vaginal seeding or something similar in terms of how it might change the microbiome for the better in the baby who may be at risk of atopy?
No, I do not have an opinion in the sense that there are a few studies that have tried that. So if I am not mistaken, one in the US and one in Finland. There are a lot of controversy around it, and the main question is indeed on the safety and on how to do it right. Because of course, birth is a natural process. So how would you really do the vaginal swab? And so I think in the future, I do agree with Patricia, looking at artificial communities inspired by the concept of vaginal swabs. So what could be artificial communities? What I mean is looking at what's dominant in vaginal microbiota, and then how can you simulate a consortium of bacteria, a community that could have an impact. That could be in the future. For now, I still think studies need to show that with that you can have an impact on the microbiota, confirm that, and have the impact on the health outcome of the babies later in life. So studies need to be done. Concept is interesting. As for fecal transplant, there is a lot of controversy around.
Yeah, I think we discussed a little bit of this in, I think, week 1, but I think obviously fecal transplant for clostridial infections, would certainly be a gold standard and better than anything we have, if you've got someone who's refractory to antibiotics. And I suppose, it is because, there's innumerable bacteria, that are being given rather than 3, 4, 5, 7. And I suppose, for you thinking about that, does it make sense that fecal transplants are better than any probiotics for C. diff, or, or can we aspire one day to know exactly which bacteria would be the right ones to give in, rather than having to give someone some poo?
For C. diff, there are studies indeed showing the proven benefit, because it's very difficult to modulate gut microbiota.
Yeah.
When you look at obesity management, for example, through fecal transplant, there are also quite some studies. The key question is, yes, you can change the microbiota with a fecal transplant, because you are replacing. It's like when you have a garden and you just put the full grass newly grown. So you can cover the surface with bacteria.
Sounds much nicer when you think about the garden than what we're talking about.
Yeah.
Rocio, I'd agree.
So, indeed, it's really, you put new grass in the garden, and yes, but for how long that will stay? Will indeed the bacterial transplant be able to finally permanently colonize and have the impact? So the experience is that it reverts to your initial microbiota when you do it, and that the impact on obesity is not sustainable. So that's why some of the results are still to come. For some applications, there is a potential. So for C-section born infant vaginal swab would have the potential, and it will have to be proven, but it cannot be generalized. That's a bit the risk. Like with probiotics, you cannot generalize that probiotics work. But for us, what we try to do in the meantime is really not using only probiotics, as we said, but in combination with prebiotics, with the food of bacteria that can steer still the colonization of the natural bacteria that you have, to make sure that you steer a natural ecosystem to help the development of the immune system.
No, that's a great answer. So I guess the addition of prebiotics to formula will change the gut flora of a baby as well, won't it? It's not just probiotics.
Yeah, exactly.
And has downstream reductions in certainly gastro and maybe viral illnesses too. And that's been established for a very long time, hasn't it? So that's very interesting. Just to go back to our patients. So, Kathy, you, as you've alluded to, you meet these, sometimes 9, 10-month-olds who are on amino acid-based formula and 4 or 5 foods. And we worry, don't we, about their sort of nutritional completeness. If you saw that baby, would you want to actively look for nutritional deficiencies? Would you recommend vitamin supplementation? Because I always really worry about these kids. What would you do in clinical practice, Kathy, in that kid where the kid's growing okay, but you're thinking this can't be nutritionally complete? And I guess obviously you have a much greater skill set than either the microbiologist or the clinicians to work that out. Would you investigate? Would you advise? Which way around would you do it?
Just firstly, I knew there was going to be a dog there, Rupert, by the way.
Yes.
So usually I work in private practice and I work with allergists, and so if I saw the need to do that, I certainly would. But most of the patients, most of the families that I've been with or seen, they seem to revert to, well, not in this case, but rice or potato, so a basic grain, a chicken or a beef or a lamb usually, and a range of vegetables. And so then often they will have enough meat. So the main ingredient, nutrient I'm worried about would be iron. And in particular, depending if they're breastfed or if they're formula fed, potentially I'd be worrying about some, maybe calcium if they're, but usually it's iron. So what I do is make sure that they get as many foods in as they can, as early as they can. Most of the time I'm seeing them quite early, so at 6, 7 or 8 months. I must admit I haven't for a very long time seen one who was in a case that I thought needed to have nutritional investigations. The one that I can remember was 8 months old. They were still only being breastfed. The child was refusing most foods. And the mum, the third child, and the mum walked into the room with the child on the breast, and the child was pulling off the breast because there was nothing there. The mum was crying and she said, "I've got no milk, he won't eat anything." And so we did investigate. We did admit that child, actually. That was a different situation, but they had FPIES, I think it was rice, and we found out a few days later while they were in hospital, having nasogastric feeds because they were aversive to everything, that they had an egg allergy as well, because the mum was giving the child some egg and had an anaphylaxis. in the hospital. But yeah, so I've only probably in my time seen lots of children with FPIES, but only had one that I felt needed to be investigated. But certainly if you feel that they're having no foods or very little variety, and certainly without, if they're not having a meat or a protein, a good source of iron, yeah, maybe do some investigations.
The same question to Shannon. I remember actually, this is a long time ago, I think we were probably both registrars, but Adam Fox, who's an allergist from the UK, and I looked after a child who had nutritional rickets, where it was self-diagnosed allergies. The child, in fact, didn't have any allergies, but was on a really very limited diet, some goat's milk, very little else, Do you see many of those kids in an allergy clinic who have nutritional deficiencies because of parentally diagnosed but probably inaccurate allergies?
We surprisingly don't. I think parents find other ways of making sure their child's diet is nutritionally replete. I do worry about sort of micronutrient deficiency, but I can't remember the last time I saw a child with rickets or who needed to be admitted to hospital because of a very limited diet. It's possible my general pediatric colleagues see more of these sorts of children, but in my allergy clinic, not really.
I would agree. I mean, often the iron deficiency, that is the child you're alluding to, isn't it? The 14-month-old, still breastfed, not really eating, has a very low hemoglobin, but because it's chronic, they're pale and not that unwell, will come under general pediatrics, won't they? But I suppose my question is, I asked this question to Kathy, but how do you, when you've got that child in front of you who's very restricted, perhaps there was a non-IgE-mediated allergy to cow's milk earlier in the piece, but now you've got the sort of 7-8-month-old child and the mum doesn't want to introduce allergens. How do you go about saying, well, look, this is not what we should be doing? What are your strategies to bring them back on side?
Once again, I show them the evidence that we have, and so the consumer websites that are available, which actually talks about the evidence. And I say, and usually I have an allergist to back me up as well. He's also said the same thing. And so I'm usually backing up what the allergist has said. And I said the best nutritional outcome for your child is to introduce lots of family foods. And the best way that we can prevent any more allergies is to get those foods in before the baby is 12 months of age. And so once we can actually talk, and we've actually had an allergist say it and then me say it, with consumer websites and other things, usually families are okay to do that. And certainly I'm finding increasingly they're actually, like one of the mums I had today was wanting to introduce a new, her baby had been diagnosed with peanut allergy. And she was horrified that the baby was 6 months old, and she was told to introduce all of the tree nuts and introduce baked egg and baked milk, because they also had a milk and egg allergy. And so she wanted to know, can I introduce all of the tree nuts at the same time? And can I do one in the morning and one at lunchtime? So she was sort of the other end of the spectrum, if you know what I mean. But
yes.
Yeah. And we're seeing more of that. They're more keen to get these foods into the diet, which is great.
No, that's a very encouraging story, isn't it, really? Because often we get the polar end of that patient group.
And I think, to be fair, I think we did see more of that many years ago. Those very restricted children, more so nowadays. The message has really got out there, and parents are sort of understanding that they know. Most of the people that I see know that they've got to introduce the allergens early nowadays.
Look, I would agree. Shannon, would you have many children who are towards the end of the first year of life who don't have a rare immunological disorder, who are just having an amino acid-based formula? Do you get many of those kids, Shannon?
Thankfully not. And I agree, we're seeing more and more parents who come in already understanding that early introduction is important, even though their child's already had, an allergy to one food group. And I completely agree, Kathy. It's so useful that the consumer groups and consumer information has come on board alongside now. because up until a few years ago, that wasn't the case. I can't speak for Australia, but certainly in New Zealand. And now that everything's totally aligned and that messaging is quite clear now.
Do you think it chronologically sort of came around the time or post the LEAP study? I know that's not the advice about everything, but obviously it's peanut advice, because I think I know parents wouldn't say I've read the LEAP study, but I guess the bits within it are in the lay press. People have read some of the advice that's come from that, and I think it was a hugely useful bit of research. I don't know whether you have a view on that, Shannon.
Oh, it was an incredible bit of research, and yes, it was peanut only, but it made sense that it would apply to other food groups.
I think it was a real game changer, to be honest. I think it was no longer speculative, and I think once again, this is sort of quoting people from days gone by, but Adam Fox, who's one of the allergists guys who's involved in that study, he was on the BBC News about as often as the Queen at some point talking about the LEAP study. So I think it really got into the lay press in a positive way. I don't mean that in a negative way. So it's really useful.
And I can still remember being at an IACI breakfast workshop where Gideon Lack was talking about his plans to do an early peanut introduction study. And I remember somebody in that workshop group getting really angry with him and kind of going, of all things, why would you choose peanut? So it has been groundbreaking.
Good. We've only got a couple of minutes left now. So I think I can't see any questions. Is that correct? Tash, are there any questions in the chat box?
We don't have any questions. Oh, there's a question that we've already answered tangentially. Do biotics have a potential role in other food allergies or intolerances?
I think we have, haven't we? I think we got some really good answers from Rocio and Patricia at the level of knowing which probiotic, and also I think it's important to reference the benefits of prebiotics in addition to probiotics, which are different, aren't they? These are these indigestible carbohydrates that facilitate increased numbers of good bacteria theoretically. So I think we have answered that, and obviously it's the eternal dream of the formula manufacturer to make a formula which is most similar to breast milk, using many of those things. Good. All right. So I'd like to thank everyone who's been involved in this evening. So thank you very much, Rocio, Patricia, and Kathy for joining us. Thank you very much, obviously, Shannon. We've done a couple of these together. It's been a pleasure doing these sessions with you. I've really enjoyed them. I must say, I spoke to one of the speakers, Sam Mayer, after our talk, and he thought it was really nice. It was just like having a chat, and I suppose that's probably what we've aimed for. So, thank you everyone who's participated, and thank you very much, Nutricia, for organising it. I think it's been a really nice way of giving some information, and hopefully it's been useful for the audience as well as us. Maybe just from the microbiologists, I know it's hard, but a one line on where we're going with this gut microbiota stuff. What are the in the next 5 years, what will I think, my goodness, that's amazing, that I don't know now with regards to the therapeutic benefits of manipulating the microbiota? So to Patricia first and Rocio.
Well, I'd like to know what is the perfect microbiome profile, so that then I can know how to achieve that. And having said that, every individual is different, so there isn't the perfect microbiome.
Rocio, what would you aspire or hope that we might know in 5 years about the manipulation of the microbiota that we don't know now that would be clinically useful?
Yeah, what we are starting to know is it's not about who is there, so which type of bacteria they are, but what they are doing. So we are learning to modulate that you get the functionality of the microbiota, not exactly which type of bacteria you can find. And learning this functionality will make it much easier to modulate it, because you're not looking for a specific bacteria, but really what you want the bacteria to do. And there are several bacteria doing the same job. So I think really in the coming years, we will be looking more at what they are doing rather than who is there, and we will be able to modulate that.
I feel like it's like a song, isn't it? It ain't what you do, it's the way that you do it, I think, for the gut flora, isn't it? But good. And any other comments, Shannon, with regards to that? Do you see, I feel like in terms of what we do, our advice, we haven't really progressed with useful clinical advice for allergists or gastroenterologists in terms of probiotics. I mean, we know the science, we know the basic science, but it's not day-to-day altering much that I do. And I think, and I made this point before, fecal transplant for C. diff is really one of the few situations where I can see it's absolutely ring-fenced as a great treatment. You know, some of the other stuff is less clear. Any thoughts from you, Shannon, about anything that you think is clinically useful in the allergy space that's really clear that you use clinically with regards to manipulation of the microbiota?
Unfortunately, not clinically
No,
useful.
I
I really want it to be, because epidemiologically there are so many signals, and it is all, in terms of food allergy, it is all about the gut microbiota. But that's why I'd love it to be in 5 years' time that we are able to use that as for treatment or prevention rather. But not right now.
Agreed. That's a brilliant way to end. Thanks, Shannon. Thanks, everyone.
Thank you.
Thank
Thank
you.
you.
Okay.